Sorry, we had a little trouble with the mute button, and actually Dr. Morris from Public Health is going to be our lead off and start talking about this virus and its nature to begin with.
Good morning, everybody. My name is Ralph Morris. I thought I would start off with just the most recent statistics for Minnesota. As of this date, we have approximately 2,727 cases of COVID. We have a total death in the state of 179. And in the county, we officially have now 6 positive COVID residents. I would like to first start off with talking about the virus in general. The important thing to remember, I believe, about coronavirus is that we're dealing with what we call in medicine a novel virus or a new virus. And there's several important ramifications of dealing with a novel virus. First of all, unless you've been infected with COVID in the past few months, everyone is susceptible to the infection. It is not like influenza, where we have a previous experience with the virus or have been vaccinated against it. Second of all, we have no proven treatment for the virus. That's something that we hope, as we go down the road, we'll be able to do that. Third, we only have partial epidemiology information on the virus, who's susceptible, how it's transmitted, how to prevent it, things that we like to know in epidemiology. And then finally, there's evolving data about the virus. Dr. Wilcox and I haven't talked about it, but I know for me, it's like a daily educational process to keep up with what's going on. Kind of reminds me of second year of medical school, where you're just bombarded with data and pathophysiology hour after hour. But I think it's really important to remember that we're dealing with a new virus with a lot of unknowns and a lot of uncertainties. The risk groups that we know of now are the elderly, and that's basically defined as those people over 65 years old. Also people with underlying disease, particularly heart and lung disease, diabetes, obesity, and not on the slide is hypertension. Men seem to be affected more than women, particularly in the critical ill stages of the disease. And what is kind of a mystery to those of us that have looked at epidemics in the past, children seem to be less affected. And we're not sure whether they're non-infected or just don't show the symptoms of COVID. And finally, and this is, I think, very fortunate, they seem to have less severe disease than other age groups. Transmission, we know that this is a contagious respiratory disease that's primarily spread by respiratory droplets and on hard surfaces. That's why one of the recommendations is to wash hands frequently. We know that both people with symptoms and people without symptoms can spread the disease. And that's when that first came out about asymptomatic people being able to spread the disease was very, very worrisome. We do not know about airborne transmission of the disease. That is still very much debatable. And finally, it looks like stool spread is possible in the latter stages of the disease. Signs and symptoms, fever as defined as over 100 degrees Fahrenheit, dry cough, shortness of breath, fatigue, and sudden loss of smell. The spectrum of the disease, between 80 and 85% of the patients will have no symptoms or very, very mild symptoms. Approximately 15% will seek medical care or have short-term hospitalization, and approximately 5% will need critical care, and that usually means being on a ventilator. And finally, and I know this number has been all over the board, but I think very conservatively, we can say that there's a 1% overall mortality to this disease as we understand it today. Prevention, at this point, the best prevention is to avoid being exposed to the virus. That means avoiding sick people. I think everybody has probably heard about social distancing. As you can see where we're sitting here at this conference table, we have spread ourselves around, staying at home, working at home. If you're out in public, maintaining that 6 feet of separation, and then washing our hands very frequently. It's a good idea to avoid touching mouth, nose, and eyes, although that's very difficult to do. And then finally, I know when I'm sitting down at a table or in a new environment, I try to get a wipe and wipe off the chair and table around me as an additional precaution. I do want to say a word about masks. The government has recommended that when you're out in public and you can't maintain 6 feet of distance, that you wear a cloth face covering. And that's not to protect yourself, but it's to protect others. A couple of key points about wearing a cloth mask is please do not use a medical grade surgical mask. We're really trying to conserve those for healthcare personnel. And when you wear a mask, it is not a substitute for social distancing. It's in conjunction with social distancing. So I think it's important to keep those points in mind. If you go to the county emergency management Facebook site, we have much more information on cloth face masks, how to put them on, how to take them off, and how to care for them. I know this weekend there's going to be a big drive for homemade masks to be dropped off at fire stations and to be distributed to the general public. And I would encourage you to take advantage of that if you don't have a cloth mask to wear out in public. I want to say just briefly what we're doing in the county, and that's basically to flatten the curve, and that's to buy time, I think, for all of us, but particularly the healthcare system and Sanford, to be as prepared as possible for what we, I think, all know is going to be happening in the near future. For those of you who have not seen the curve, these are two representations of epidemiological curves that we see in outbreaks. And without any type of intervention, whether it's social distancing or a vaccine or any other measures that we can do in an outbreak, you'll see that high peak of cases. If there are protective measures that we can do, like we're currently advocating in terms of social distancing and staying at home, that curve will flatten out, as you see on the bottom there, where protective measures are taken. One of the really take-home points that I would like to emphasize, if you look at both curves, the area under the curves are the same. That means we're actually not reducing the number of people who will get ill. It's that number, whether it's 40% of the population, 60 or 80%, is still going to be the same. What we're trying to do is spread it out over time so that all the aspects, particularly in healthcare, can have time to adjust so that we can have all the PPE that we need and hopefully be able to develop specific treatments for the virus, as well as time goes on, have a vaccine available to prevent the disease. Some of the strategies that we're doing specifically here in Beltrami County is we're working with our internal county partners as well as external county partners. It is really quite an undertaking. I've been involved with this for about 4 weeks, and it is it's really amazing the cooperation that we're getting just from all sectors in the community. Internally, we're working with internal emergency management, the sheriff's offices. Fortunately, our public health office had been combined in one department with social services, and that's making a lot of services much easier to do. And then finally, we're working with other departments as we find need for additional people to help with a variety of activities. I really cannot say enough about Sanford and the cooperation between public health and them. I think just the fact that we're in the same room right now and I'm giving a joint presentation speaks to that. But there's all sorts of cooperation going on between Sanford and the county in a variety of areas, and that would almost take another hour's presentation. We're working very closely with BSU for a variety of possible housing issues that we may be faced with in the county. And a little bit later on, I'm going to talk to you about possible volunteer opportunities. We're also working with the tribal governments. There's just a variety of issues in terms of dealing with quarantine and isolation, and we want to be sure that we're working hand in glove with them. One of the special populations that we're very concerned about are congregant living settings, and we're working because we know that that's an area where COVID can really do a lot of devastation very quickly. So we're working with skilled nursing facilities in conjunction with Sanford assisted living and adult foster care. I really can't mention because they're too numerous to work with our other partners, but they include city and local governments, schools, faith groups, homeless shelters, and many more. One of the big activities that we're doing right now is trying to define or locate isolation and quarantine shelters. We've had 6 cases in the county so far. Most of the time when we have a positive case, they have enough resources to go back to their home and isolate themselves, and they have people, relatives, and family members to help take care of their needs. However, there's other situations where individuals do not have an ability to do that, and that's where the county really is stepping in to locate isolation facilities. We provide what is known as essential services, and that's everything from food to medication to anything an individual may need to help them go through the isolation process. We also are looking at quarantine facilities. That's where someone has been exposed to the virus, but is not necessarily ill. And we also work with individuals that don't have any shelter available to them and providing essential services to them. We're also in the process of identifying community volunteers for possible future staffing needs. As we start seeing more and more cases here, we could see a shortage, particularly in long-term care facilities, where we would like to have a reserve pool of people to help not only with nursing and nurses' aid services, but whatever we may be facing in terms of supporting those facilities. If there's anybody listening to this presentation, I would like to refer you to www.Minnesota Responds. That is, it's actually it's administered here locally in the county, but it's a state program where potential volunteers can go online and register as a volunteer. Yesterday, the governor activated Minnesota Responds, which means that if you're an approved volunteer, the state picks up all liability issues for the volunteer as well as workman's comp. So that's a big step forward for us in developing a pool for future staff needs. And finally, this is my last slide. And this is, as you look at that and kind of digest it, this is a dilemma that any of us in public health have really faced in all of our careers, whether it's an epidemic, flood, snowstorm, hurricane, you kind of name the disaster. And what we want to do in public health is not over-prepare or under-prepare for the disaster, but particularly with coronavirus, because it's something like none of us have ever seen. At the end of the day, 12, 18 months from now, I personally hope to be criticized that we overreacted, and you can see it wasn't so bad. I don't want to be in the place where people say, you didn't tell us it was going to be this bad, you should have warned me. So that's kind of what I wanted to close on for my part of this presentation, is that it's very difficult to have an exact response to a disaster like this, because there are, quite frankly, just too many unknowns. Thank you.
So I'm Dave Wilcox. I'm a family physician. I've practiced in Bemidji for about 30 years. My current position is the Vice President Medical Officer for Sanford Health. Also with us, we have Jay Ward, who's our Emergency Preparedness Director. And without his efforts, he takes in 1 million pieces of detail every day and seems to manage them and keep them coordinated. We activated what we call our Incident Command, which is our crisis planning group, a month ago, 3 weeks ago?
March 12th.
Yeah, so it's going, it seems like a long time ago, but it's really not that long ago. And we've been doing a lot of planning related to COVID-19. I can't stress enough the concept of the area under the curve and flattening the curve. Dr. Morris is exactly right. The area under the curve is the same. Just as many people will get sick, just as many people will be in the hospital, just as many people will be on ventilators if necessary. The only thing that we managed to do is maybe avoid some preventable death. If that peak is too high and too soon, our health system will be overwhelmed and people will not be able to obtain the services they have despite the amount of surge planning that we do. So that's really important, and it's very tempting right now to say this is going to go away. The other key point is that the country is operating in a different way in different areas. So far in Bemidji, we've only had 8 cases of COVID identified, none of whom have had to be hospitalized. 7 of them were identified over 2 weeks ago, so they were really the residual of exposures to other patients in other communities that they'd lived with or been visiting as family members. The new case also was exposed to a known COVID patient from outside this community. We've had no one in the hospital with COVID-19, and so we feel quite confident at this time that we don't have community spread. The problem with that is most of the discussions about opening up and relaxing restrictions are for communities that have had their COVID-19 outbreak occur. So there's quite a few number of people who had mild or no disease and are now immune, and it's safe for them to go out into the community. We're faced with a naive community where if people from the outside area come in shedding virus, we remain non-immune. So relaxing restrictions significantly here could be a danger to us. Now, it's unrealistic to think that our country will be as tightly tied down as is right now for the 12 to 18 months that it will take to develop a vaccine or get some prevention. But nonetheless, the activities that the citizens have undertaken to social distance, to avoid the large groups, have been very important. Returning to activities will be very different activities. It'll be restaurants perhaps open with tables 6 or 8 feet apart. A restaurant that used to have 12 tables will have 4. That kind of thing has to continue. And it has to continue till we're immune. And that is a long haul, or the development of vaccine, and that just doesn't happen overnight. So that's critically important as we're in this environment now where we're talking about relaxing some of the social distancing and recommendations. How we've dealt with it at Sanford is we talk about turning up the dial. So of course, with our employees every day, there's been questions about, how much is this in our community? When should we be wearing a mask? When should we stop or start certain activities? And so we talk about it, that there's a number of opportunities that we can take advantage of, and we will use them appropriately depending on how much disease we see present. So I'd like to spend some time talking about how we've prepared at Sanford. And again, the relationship with our community has been unbelievable. Public health has really stepped in and been a part of the planning that we undergo. We rely on the community for those needs that we cannot provide, such as the long-term care and the other facilities for sheltering and the homeless shelter. And we've had some great community members step up. We'll talk a little bit about testing, because there's always conversation about testing. How much is too much? How much is too little? Who should be tested? We'll talk a little bit about what modeling means, because you hear that in the news a lot. And we'll talk about what we've done for surge planning. So disaster planning and epidemic preparation is not new to Sanford. We actually have a committee that we call our Emerging Threats Committee, and we started planning for this as far back as January, in addition to our quarterly meetings where we deal with things like the annual influenza epidemic. So every year we meet quarterly, we talk about what's on the horizon, and of course we saw this coming on the horizon back when it was in China as a potential pandemic. And started making preparations. Some of the highlights on this timeline were the first cases in Minnesota in March 6th, but we were already screening patients at the front door and at check-in to Sanford back in February. And those screening questions related to being sick, had you traveled to an endemic area, or had you been exposed to someone with COVID-19. The risk was low in the United States at that time, but nonetheless, with world travel and being able to circle the globe in a day, we have to be aware of these diseases that can sneak in, if you will, undetected. In March was the first case in Minnesota. In March 11th, down in the bottom, we restricted visitors for the senior living as recommended since that's such a vulnerable population. Later, March 13th, we restricted visitors in the hospital as an effort to protect our patients. We recognized early on that testing was going to be a problem. Early testing at the state was getting to be 7 to 10 days before you'd get a result back, and we couldn't manage very well. So we stepped up opportunities for us to perform testing alone as Sanford. We switched over to Quest, and with the increased volume, they were quite soon having a 7 to 10 day turnaround. So again, that was not possible. We began collecting samples at an alternate test site to keep our facilities free of COVID disease the best we can. So if someone's not too sick, they could call into Sanford and get a test collected and go back home to quarantine if they're not that sick. And that began on March 17th. Some events about schools closing, governor's cancellations and declarations of emergencies, and stopping elective procedures. You have to be aware that most of that was driven by the activities going on in the Twin Cities for fear of being overwhelmed. Since we've been free of disease, that's been a bit of an inconvenience for our patients and our staff here to have that taken away as a government mandate. So we beg forgiveness for all of those who are waiting on certain surgeries. Perhaps they're uncomfortable with knee pain or arm pain or something that was going to be fixed, but we're following the state guidelines for that. Our first case in Beltrami County was on March 25th. Just to be aware, you'll see differences in the data because cases are announced by the person's home location, their home address. So thinking that it's there's 5 cases in Bemidji, they may be tested somewhere else and gotten sick somewhere else and maybe even treated somewhere else, but their home address would be in the Bemidji region. We began a separate evaluation clinic back on March 30th, and that's if people who have upper respiratory conditions, we always ask you to call first so that we can tell you to go to the right location. And all patients with colds, coughs, and fevers that would be suspicious for COVID are sent to a separate location to be evaluated. Again, it's a way to keep the remaining population in the hospital and our other clinics safe. Because this was endemic in the United States, we took away travel questions. So now we're basically screening people if they're sick. And in a nod to testing, we started rapid testing at about a 1 hour turnaround here in Bemidji back on April 3rd. Now to protect the public, we're masking all of our employees that provide care. We do temp tracking for everyone who comes into our facility every day to make sure they're not sick and have a fever. And then we stood up our rapid testing in Bemidji just this last week. So we've got good access to services here. I'll talk a little bit about testing. I mentioned the alternative collection sites. We test by CDC guidelines. Because the whole world is suffering, there's difficulties with supply chain. So just getting reagents to run the test, getting swabs to collect the test can be a problem no matter how fast or how high a volume your machines will handle. We have alternate collection sites in Bemidji, Bagley, Walker, and Park Rapids for folks in those regions. I'll talk a little bit about testing options. We have a reference lab through Sanford that does large volumes of testing. It's state-of-the-art technology that is very reliable with close to 100% sensitivity and 100% specificity on knowing whether or not you have a virus. We're using that for all our test sites that are in patients who aren't in the hospital. Fargo had some testing that was about a 24-hour turnaround that was adequate. We were using for inpatient, and now with our 45-minute test, we can use that basically to decide if patients need to be isolated or not in our facilities. That testing is not available to the community because we need to preserve that level of testing for what to do with patients. And that's the controversy over testing. When the supplies are limited, who do you test? So right now we test people who have symptoms primarily, and early on it was symptoms and exposure. Now it's symptoms or exposure to COVID-19. And again, you access that test by calling the clinic at our usual numbers and going through a a series of questions about what you're calling for, and you'll be directed to the respiratory clinic nurses if you're curious about COVID or symptoms related to that. I'll talk a little bit about modeling, and there's several different quote-unquote models, and what a model is it's a computer program that takes a lot of data in and comes up with a prediction of what might happen. The models are driven by data, so the more data and the more accurate data you put in, the more accurate of an output you get at the end. The model changes as you go. The technique doesn't change, but the inputs change. Many of them are driven by how many patients in a community are in the hospital, and that seems to be the trigger of when the curve is rising. So far, we've had no patients in the hospital, so our data is not as accurate as we would like it to be. And I'll go through some of the predictions our early modeling and our current modeling has come up with. In Bismarck, these are the 4 major sites of Sanford Health in the Midwest. Bismarck early model predicted that they would peak around the end of June. They currently have just a few patients in the hospital, 4 or 5. They had quite a few patients in the hospital a couple of weeks ago, which was that first rush of people who got it somewhere else. In Bismarck, they're probably having a low level of community spread. The model predicted somewhere around mid-June, and with the delay, the model now is predicting end of June will they will hit their peak, and the model predicts that they will have approximately 142 beds per day necessary and approximately 30 ventilators necessary to do their work. It's important that these models do not predict what decisions should be made politically. They don't predict what will happen in a community. They're only used for internal planning for us at Sanford Health to decide what changes we need to make in our facilities. Do we need to go out and get access to more physical beds? Do we need to make more rooms available for patients to be seen above and beyond what normally occurs in our facility? So it's only for planning purposes. It's not to predict what will happen in a community, because things like social distancing, things like opening up sporting events or whatever would make a great impact on what the model predicts. Our data changes as those inputs go. Right now, Bismarck is right about where we predicted they would be with our first run of the model, and they're into their second run of the model. Fargo predicts that they'll peak sometime in early June. Sioux Falls predicts that they'll peak sometime in early June as well. Those are the ballparks for what they thought they would need to prepare above and beyond their normal facilities. So with no inpatients, our data predicts that we will be farther out. We know this disease will come to our community, and people will need to be in the hospital. But with nothing happening yet, of course, an infectious disease will run its course at a certain pace. So the pace that it runs seems that we will have a surge close to the end of August. This model includes the current social distancing and a slow return. It does not include releasing everything automatically. If that happens, we will go back to an immediate peak that might overwhelm our services. So the model for us predicts that we will have 51 extra beds needed above and beyond our usual capacity. And it will predict that at current we would have about 10 patients that would need ventilators. The reason there's 2 numbers there is that our model uses what we consider our usual market share. So this is the number of patients in Bemidji that would expect to be hospitalized in Bemidji. Our region includes International Falls, Black Duck, Bagley, Baudette. Lots of facilities send patients here, but some people choose to go to other hospital systems. So using that model, we think we need about 51 extra beds. If we get all of the patients in the region, we need 113 extra beds. Our known capacity is 105 beds currently, and typically we're about 75% full. So if you add 75 to 51, you can see we don't have that many beds in our hospital, and we've had to make an accommodation for that. The other ventilator prediction is the idea that we would predict how many ventilators by our market, which is not all the patients in the region, but we are the only facility in the region amongst our local hospitals that has a complex ICU and can manage ventilator patients without much extra stress. So if we got all of the ventilators, we would need 22. We've resourced ourselves up to about 30 ventilators, so we have extra capacity should these excess number of admissions occur. The changes that we've made is we have redone our entire 4th floor to be an alternate care facility or a special care unit for COVID patients. We did that by what you see in picture 1, filters within the room that exhaust the air out into the environment and spread it out so that it doesn't stay in the hospital and contaminate our staff or other patients. We've had to do concepts like a ward. So in the left lower picture, you see 4 hospital beds in a room as a group. So that used to be a dining facility. So we've put 4 beds there. On the lower right, you can see a couple of what looks like, I'll call them a stall-like. That's a large, what used to be a gym up in the 4th floor. And we've been able to put 9 beds capable of ICU care as well as hospital care with oxygen and electricity and data ports. So this won't be the usual single room that you get when you come to the hospital most of the time. This will be a ward-like service. With these changes, we can anticipate up to about 20 ICU beds. Many of these are flexible and could be an ICU bed or a standard hospital bed. And we've probably added close to 50 extra beds to our facility for an entire capacity approaching 150 or so beds. So those are the arrangements that we've made. This includes our normal ICU, which we would want to keep free of COVID patients, but we would have to move that to another area and evacuate our special care nursery to another area because the special care nursery becomes our standard ICU. Once we get past that, we will count on sister facilities. We will transfer patients back and forth with our community hospitals. So up to International Falls, down to Park Rapids, where we have agreements to take some of their COVID patients, and in return, they would maybe take someone who's recovering from a broken leg or something that doesn't have COVID. So it's taken a real relationship building opportunity with all of our community, with public health, and many other regions. Providing these estimates of our needs are good. We believe we have appropriate personal protective equipment, PPE, provided we use it as appropriately and conservatively and don't waste. So we have all of those things that have happened for Sanford Health. It's important to understand what we're seeing right now is, I'll go back a slide for now, is that unfortunately with the stay-at-home order, people have considered their healthcare a non-essential service. And so they're letting go some of their chronic problems like diabetes, congestive heart failure, emphysema, lung disease, heart disease. And they're getting sick and ending up in the hospital unnecessarily because they're letting those problems go. So this is of great concern to us because if you have a chronic disease and it's poorly controlled, that alone puts you at higher risk of getting COVID disease, and it puts you at higher risk of having a poor outcome from COVID disease. We're going to great lengths to isolate COVID patients and to keep our normal processes going. We've instituted a lot of video care, which is an option for patients, telephone care if it has to be, but we're urging the community to continue to connect for their chronic diseases because right now when we have no disease going, it's safe to come to the clinic and the hospital. We're screening all of our patients that walk in the door. We've limited visitors. We've social distanced the lobbies. And so our fear is that these chronic diseases start coming out of control about the time we're having a surge. It almost increases the overwhelming nature of that surge and might put us in a difficult way for providing care. So that's a message, is to get your chronic care in a way that is comfortable for you by calling us and making sure you take care of those things in advance. So in closing, The couple of things I want to bring is those social distancing and staying at home. It's working. It doesn't mean we should stop it. We're simply flattening that curve and trying to distribute this. I believe our community is at risk. As other parts of the country start relaxing, we'll still be that immune population that's at high risk of having a surge. And it could be worse than we anticipate because of that. We're seeing good effects from the work that's happening. And I think we need to, if we do come back into more activities, they need to be done in a very slow and stepwise fashion. The shelter-in-place order will be under the control of the governor, so we don't know what that will do to our community as that potentially gets relaxed. And we're concerned about the delay in care of chronic disease. So we would ask this group to be ambassadors for that message. Healthcare is an essential service. You need to continue to keep up with your healthcare in a safe fashion the best you can. Don't let those chronic diseases go out of control, because that's a much higher risk for anyone. We kind of have a new normal, and hopefully this will be a learning experience about smarter health practices in the future. And so that's about all I have to say. We have some time left for questions. Anybody that wants to chime in, I guess I would stop sharing my screen and turn this back to Andy and entertain your questions.
Yeah, that was really fantastic. So first, before we take questions, thank you very much for coming today and for sharing all that information with us. That was really, really great. So for the people who are in attendance, if you have questions, please submit them using the Q&A tool, which you should be able to find at the bottom of your screen. And I'll moderate the questions that come in just as we have in our previous campus forums, and get those to our guests from Sanford. The first question is in already. It comes from Samantha Jones, and she asks, what plans are in place for follow-up testing to ensure that recovered cases are no longer contagious, given new information showing continued positive tests and viral transmission after recovery or with no symptoms for up to 2 months?
I'll take that, and it really speaks to the fact that we know very little about this virus and what really happens. You're hearing a lot of buzz about the asymptomatic spread. You're hearing a lot of buzz about the importance of antibody testing. But to be honest, there's no data that proves that if you have an antibody that you can't be contagious. And so we know the course of the disease is onset within 2 to 14 days. The current recommendations are to self-isolate for at least 3 days, not the usual 1 day, but at least 3 days after a fever, and all symptoms gone for at least a week. We know no more than that. So follow-up testing for ongoing shedding, we don't even really know if you're shedding virus after you're healed, if that virus is as contagious as when you're early or middle of your disease, when you're coughing and sneezing a lot more. It's important to remember that although we talk about transmission from hard surfaces being a possibility, the known transmission is close contact with an infected person and inhaling, touching, or introducing droplets into your body. That's still very most common way. So healthcare providers are managing to stay uninfected by good hygiene, by protective equipment. Family members are managing to stay uninfected by isolating the sick person in a room with a mask and good hand washing and techniques of cleaning.
Okay, thanks. The second question comes in from an anonymous attendee, and you touched on this just a little bit. But the attendee asks if you could maybe talk a little bit more about herd immunity and when that might be a factor for our region.
The question is about herd immunity and when that becomes a factor.
Again, we're dealing with a novel virus, so different diseases have different levels of herd immunity. The two ways to obtain herd immunity is through natural infection, and then the second way is through vaccine. I think the best guesses at this point is that it's going to be at least 18 months to 2 years before we'll even approach a level of herd immunity. But that will be a big milestone when we get to herd immunity for all of us to be able to return to somewhat of a normal life again.
Okay. So for this next question, for social distancing, why are we gathering our elderly into a single facility to open up other facilities for isolation when we are not at our peak?
I am not aware of any gathering other than what was existing pre-COVID for elderly. There's been talk of, or various groups have been talking about establishing what are called preventive homes, where elderly would be housed in one facility. There's kind of pros and cons to doing that. If an elderly person is in a 3-generation family, that does present a increased risk for them. On the other hand, if you gather elderly into, say, one apartment complex or one building, and the virus is introduced into that building, then you could have a catastrophic situation. So it's that's a tough one. I don't have a good answer for that, and we're all learning as we go down this road.
Okay, thanks. The next question is whether there is antibody testing available in the Bemidji community yet.
I am personally not aware of that. Jay, do you have any?
Not at this time.
Yeah, not at this time. And that's actually going to be one of the big breakthroughs as we go through this pandemic, is to be able to have good, reliable antibody testing, but that's much easier said than done.
Okay, the next question is, does our community emergency response have mutual aid agreements with other communities or agencies in the event that we start having staffing issues with healthcare, law enforcement, public health, etc.?
In most emergencies and disasters, we do have mutual aid agreements with surrounding communities. One of the things that makes COVID such a challenge is that if we start having shortages of supplies, staff, or people, then the surrounding communities will probably be in the same boat that we are. I think as we go down through this pandemic, as one region experiences a surge and then it declines and another region picks up, I think there will probably, and this will have to be coordinated at the state level or at the national level, of people moving from region to region to help those areas that are under a surge. If you look at the history of the 1918 flu, that's exactly what happened, is doctors and nurses and other healthcare personnel traveled around the country to help areas that were being overwhelmed.
And to add to that, our hospitals have been meeting for the past 18 years. We've got a coalition, our Northwest Minnesota Coalition, which includes the 15 hospitals in the northwest corner. The interesting thing is we drill together annually, but it's always evacuating from one facility to another. We've never exercised an actual event where we were all in crisis mode like we are today. But we do have a good MOU. We've got good working relationships between our hospitals, and that includes not only sharing plans, but sharing resources.
Okay, thanks. Then we've got a couple of different questions that are related to this topic and whether the modeling for Bemidji includes potential summer tourists from other regions of the state or country.
Absolutely does. That was one of our big concerns is the snowbirds. I've been in Florida or Arizona, which have been kind of hot spots, or I'm coming up to my cabin right now from Minneapolis. So we did our best to try to measure that, and then we included that in our models.
Okay, an anonymous attendee asks whether people with regular wellness exams, if you are otherwise healthy, if they should consider postponing those until the fall.
I think that's reasonable. I would leave that to the individual physician who knows you to make that determination. We're doing care a number of ways through video visits would be an option. And so you could take care of that through a video visit at your usual time as well. It lacks a little in physical exam findings, but I'm discovering how well I can see something that's red or hot or swollen or a bump or something, or a skin lesion on a video visit. So I would contact your provider's office. The clinicians are screening through their appointment schedules and looking at who would be appropriate to a video visit. And they're also looking through who should really come in because it's necessary to have a hands-on part of the exam. And just a reminder that we've done everything we possibly can to make it safe if you need to come in. Every person who enters our building is asked if they're sick, asked if they've been exposed to anyone with COVID, and asked if they have a fever. Every employee's been temp tested every day and is masking if they come into contact with patients. And they also get the same questions and are asked to show up and are put in quarantine if there's any risk.
Okay, thanks. I think you'll enjoy this next question. It comes from Samantha Jones, and she's wondering if you can provide some insight into why or how so many people are asymptomatic and why the virus seems to affect different people so differently, some in the lungs, some in the heart, some in the kidneys, and whether new information showing similarities between COVID-19 and HIV is affecting the medical response.
I think with every disease, every infection, there's a period of time where you're exposed. There's a period of time where your body is trying to fight it off, and you may shed a little bit of virus, and you may not have symptoms yet. Then that immune response accelerates to where you cough, sneeze, wheeze, get a fever, whatever symptom that disease is a specialist in. And then there's a time where, in this case, the immune system overwhelms you with secretions so that you have difficulty breathing. Your lung tissues get so swollen that you can't exchange oxygen. And then there's a period of time of recovery. And virus shedding can last a short period of time or a long period of time. The media likes to talk about the exceptions being the norm. So the buzz about antibody testing being a cure, for example, and it's all going to be great. Well, we just don't know the science of it. That's just the latest thought. So this disease will have a course of time. There will be a large group that will do the average thing. There'll be a small group that will do something unique, like get sick sooner, or shed virus longer, or get sick enough to need a ventilator. It seems to be the chronic illness and age, and I think that has to do with how your immune system functions and what kind of resources your body has to fight. So if you already have poor lungs or poor kidneys or poor heart function, then a virus affecting that is going to put you at higher risk of getting more seriously ill.
On just a general basis, that's what makes epidemiology so fascinating, is to look at why some people get sick and why some people don't, and why some people have one course and other people have another course. And this coronavirus, at least from a scientific standpoint, is a very fascinating disease as we hopefully understand the disease and uncover the questions.
We'll have a lot better answers to your questions somewhere between 18 months and 2 years from now when we know what happened. and can gather data.
Okay, the next question that I'll bring forward is, what advice do you have for people who are traveling by car to visit family cross country this summer?
What advice do you have for family who's going to travel by car across country?
My first response to that would be to avoid doing that. You're exposing yourself to potential virus, as well as you're exposing the family members that you're visiting. And I would particularly caution if you're dealing with vulnerable groups. As I mentioned earlier, people over 65 and people with underlying medical conditions, that this summer is really not a good time to be traveling around visiting family. And I don't know if I'll pass back to Dr. Wilcox and see if he has anything to add or contradict.
Yes, no, as that goes, and all I can think about is if I was a party to getting somebody else sick and they had a poor outcome, or some family member of mine came and I became ill and had a poor outcome, I think that would be a lasting moral injury that I would have a hard time facing as a person, because I've gone through this exact decision about what to do. My family lives out in other states, and so they would have to come or I would have to go. So we've pretty much canceled those plans for the summer because I wouldn't want to deal with that moral injury if I had a party to a poor outcome for a family member.
All right, thanks. We're not going to be able to get to every question that's in the Q&A, but the last one that I'll bring forward, I think, will be a good one. And this is whether some understanding that Native American populations may be more susceptible to COVID-19 could be a result of increased amounts of other chronic diseases amongst that population.
I think one of the really sad issues about this pandemic is that it's truly shining a spotlight on health disparities. And the Native population has a number of challenging health issues, and the pandemic is really showing a light on that, as it is other groups of people that have health disparities. That is something that is very much of a concern of us in the county in responding to the pandemic, and I believe that is equally true for Sanford.
Yeah, we're very concerned about our Native community. We serve a great number of our Native community here because of our geographic location with our reservations, and that's of great concern to us. We want that all of our communities to be well protected and well served, but the health disparities issue is very clearly a problem.
All right, well, that brings us right up to 12 o'clock. So thanks to you both again very, very much for taking time out of your day to join us. I think that I speak for everyone in saying that this was incredibly useful and valuable, and we appreciate your time this morning very much.
And we'd like to say thanks for the opportunity. Dr. Morris brought this to my attention as part of our working together. I really appreciate it. And kind of my take homes is there's a lot of buzz in the latest thing and a lot of things cruising around the internet that are taken as fact, and a lot of them are fiction. And they tend to lead to a little bit of hysteria. I think a level head, doing what we're asked as citizens to protect our communities and our fellow man and our neighbors is really important. And although some stretch can be made about these modeling, they're not intended to predict what will happen to a community. They're intended for planning purposes for the medical community to know what to prepare for and to try to prepare appropriately.
I couldn't agree more.
And I just want to say thank you both so very much for being willing to do this. I know you're in a very busy period of time yourselves, And I've had the opportunity to meet both of you, maybe not in person, but over the phone through the Beltrami County EOC meetings, and really appreciate the wisdom that you share. We do have some questions that came up yet, and I'm wondering if it would be possible to forward those to you and see if we could ask you to answer some additional questions that came out of this session.
We're both looking
Is
at each other.
it 2 or 200?
No, it's just a few.
It's 8.
8 questions.
Okay, that would be great. You want to divide and conquer?
Yes.
Send 4 to Dr. Morris and send 4 to me at my email that you guys have, and we'll go from there.
Yeah, we'll do our best.
Thank
Okay,
you so very much. We appreciate
Well, Andy, will you take care of that? I'll look for emails from you, Andy, and respond directly to you.
That will be perfect. I'll send them to you later today.
All right, thanks a lot.
All right, thank you.
Thank you very much.
Thank you.
You know, I think we could probably start a syndicated